Welcome back from break. Welcome back for break. This is primarily a parenteral nutrition, but also anybody who has long-term chronic access to vascular access. I know that there is a slight change in schedule because some other presenter has not made it. So we're going to go with this. Thank you for your patience and a little delay on getting the air wall closed today. Today, I'm so excited to present critical issues in chronic central venous access. I think it's an interesting thing in that, and maybe I can have the speaker talk about this somewhere, what physicians and clinicians consider chronic access. Maybe you can answer that question. Because yesterday you saw this 2.5 years, that's not really there yet. They're a newbie, right? So our perspective is a little bit different sometimes as the consumers, right? So today we're going to welcome up an interventional radiologist and a good friend of mine, Dr. Kevin Baskin.
Well, I hope you can hear me. So, and I hope this thing works. I'm sure it will. Well, welcome and thank you so much for the honor of having me come chat with you. I'm hoping in the course of this conversation to begin a dialogue. Hopefully we'll get to know each other over the years, and along the way, I hope I can be helpful to you. I don't have any disclosures, and I'll tell you that the gist of the objectives of this session are really to help you guys to understand more about common venous access misconceptions and challenges. I want you to know the risks of access, but more so what can be done about them. And I want you to understand the need and opportunities for collaborative management, for you to be a part of your own care, and to become experts in the art of self-advocacy, to band together whenever possible with others who have similar concerns, including people like me, who provide some aspects of care, and people like you who are consumers. My objective, our objective, I hope, is to provide a venue to ask the questions that are important to you, because at the end of the day, this is about you, not about me. There's going to be a panel discussion this afternoon. Ask more questions there. I'll be happy to answer what I know. I will say that depending on who's in the room, there will be people who disagree with things that I say, and I'm okay with that. 50 years ago, Stanley Dudrick first used chronic central access, and in answer to Beth's question, from my perspective, chronic access is anything that lasts more than 5 days. Now, you all started somewhere at day 0 and got to 5 days. Now you're well beyond that. But the impact that access has on you begins with that first line and continues through your life. And the decisions we make at day 0 and day 5 have ramifications that perpetuate through your life. So yes, you may be 5, 10, 20 years down that path, but each decision is important. And the more we consider prospectively how to preserve access, the better health you will all enjoy. So his first patient had 16 catheters at 5 different sites over 22 months. How many in here have a record that equals or exceeds that? Probably many of you, right? And he, at that time, 50 years ago, said, wow, there are issues with these access devices. They frequently cause infection. They can cause venous injury, clotting, inflammation, fibrosis, obstruction, and progressive loss of central venous capital. And I think of it in terms of capital, like your bank account. You start with your bank account full, and people try to empty it over time, and we want to keep it as full as possible. You've got 6 pathways, major pathways, to your right heart. 2 in the neck, 2 in the arms, 2 in the legs. Once you use those up, you're on borrowed time. But I want to reassure you in the course of this talk that that's not the end of the story, and we'll talk much more about that. But it's interesting that today we face the very same problems. Nothing's changed in 50 years, which is a judgment of the quality of care I provide, unfortunately. So there are things we know. We know that over 8 million central catheters are placed each year in the United States. We know that infections carry an estimated 12.5 to 25% mortality. We know that there are enormous added costs related to central access related complications. That $20 to $60 billion isn't for central access, it's for the complications of central access. And we know that patients who require chronic access are at greatest risk. There's lots we don't know. I'm going to go over a dozen slides of things we don't know. We don't know where these catheters are being used, how many are intended for chronic use. The device doesn't change, right? But the purpose of the device does. We focus a lot on temporary lines, permanent lines. Are they different? And if so, how? I've seen temporary lines in for months. Doesn't that kind of make it chronic use? Okay, so how many are for parenteral nutrition? How many are placed in kids? How many achieve end of therapy outcomes without complication? And who places these devices? How do they do it? Where do they do it? And with what level of success? We don't know any of these things. We know that there's a high mortality related to infections, but how do we define infections? How many catheters are infected each year? How do they get infected, and how do we prevent infection? We don't know the answer to any of these questions. Lots of costs, but what are the actual costs of complications? Not just what we pay for them. What does it cost? What elective decisions contribute to complications? We make decisions before we put in catheters, at the time of insertion, and throughout the continuing lifespan of the catheter, but we don't know how those decisions impact outcomes. What are the social welfare costs? How much work is lost, school is lost, time with family is lost and impaired as a consequence of this process? How can we account for cost-saving strategies? If I keep people out of the ICU by preventing infection, the ICU gets angry because they've got fewer beds filled. Right? They don't look at it as cost savings because it's money they didn't spend. It's also money they didn't take in. What are the impacts on the quality of life of patients and families? We don't know the answers to these things. You probably know individually the answers for you and somewhat as a community. Patients who require chronic access are at greatest risk of complications. Who are these patients? Those with intestinal and renal failure, congenital heart disease, pulmonary disease, neonates, burn patients, hematologic disorders, parenteral nutrition, immunocompromised patients, those with thrombophilias, and those with difficult access, at least. Some of you have multiple categories. What are the signs and symptoms? Allie was just showing me some visible veins on her skin. That's a symptom that something's not going right, right? But what does it mean? What does swelling mean? What does fever and shaking chills mean? How should we respond to these? So I'm going to look at some of the dimensions of the problem, beginning with the clinical dimension. So loss of a line can mean loss of life. It's our job to make sure the two aren't equated. Lifetime central access needs are unknown at the time you begin this process. You don't know how many years you're going to require access. Loss of venous capital is cumulative and to a degree irreversible. Complications contribute to loss of central venous capital, and they relate to elective decisions, often those made at the time of insertion. But if you think about the person who put in the line and the related complication that may occur months to years later, nobody calls that person back and says, hey, by the way, did you know? If they did make that call, likely the person on the other end of the line says, months to years later, Pshaw, must have been a nurse, must have been a home health care worker, must have been somebody else, must have been the patient. Couldn't have been me. There's poor feedback to the elective decision makers about the consequences of their decisions. There's other things we don't know. The safest place for a catheter tip. We get lost describing places we can't see. Can anybody see a vein on that chest x-ray? Can you see a heart chamber? Well, then how can we talk about the relationship of the catheter with where it is in the venous axis if we can't see places in the veins? But those descriptions are made tens of millions of times a year on chest x-rays, millions and millions of times a year at the bedside. Oh, I put the catheter. Well, how do you know that? Well, because they said so. Safest place to enter the venous system. The literature is confusing and contradictory. The evidence base is skewed and incomplete. We all describe our leg of the elephant, but the elephant is the truth. Our leg isn't the elephant, and our description of the leg even less so. Properly done, virtually any site can be safe. Unfortunately, access is alarmingly often done improperly. Access events are seldom described completely and accurately in the healthcare record. The rate of central line-associated bloodstream infection, or CLABSI, there's at least 37 different definitions in the literature of what constitutes CLABSI. There's one from the National Health Safety Network of the CDC, but that definition is seldom actually applied, certainly not uniformly. Data is self-reported by institutions without external validation, remembering that if they accurately describe how often these events occur, they suffer value-based purchasing and healthcare-associated infection penalties, economic penalties for reporting the truth. So you can imagine how encouraged they are to do that. Catheter day data is therefore often virtually meaningless, but we're organizing all kinds of interventions around these metrics. January, our complication rate was here. February, after we intervened, it's here in March and April. But January of next year, it's back there. What happened? Well, what happened was we quit being able to fool ourselves into believing that this is where we really were in January and February, because our intervention didn't have the expected outcome, but we measured it as if it did. For clinical questions, CLABSI is the wrong metric. It's an epidemiologic variable. Catheter-related bloodstream infection is the clinical variable. But if you read the thousands of papers written about central access, I've seen one literally in 3,000 that accurately used CRBSI definitions. One in 3,000. Lots of them said CRBSI, but they were actually CLABSI. And again, 37 is probably a gross understatement of how many variations So we can't compare from experience to experience, and we can't believe in the validity of any one experience that's expressed in these studies. So what do we do with the conclusions? Oh, hitting the wrong button. Reporting for chronic catheters is erratic. It's especially difficult for discharge patients. If we're doing a poor job in the hospital, once you leave the hospital, it's highly irregular. The majority of studies are in ICU patients, but the majority of complications are not. Outcome reporting has economic implications, as I mentioned. There are economic penalties and public image penalties for accurately reporting complications. Purchasing strategies have economic implications. Do we purchase the best catheter with the best long-term outcomes? No, we purchase the cheapest catheter with the lowest per unit cost. That's what group purchasing organizations do in collaboration with the vendors. I sat in several meetings with these folks and said, well, yeah, but 10 years down the line, what's the outcome? They said, well, we don't do that. Well, how can you make rational purchase decisions that impact the lives of patients if you don't know or care? Economics leads to clinical and ethical dilemmas. Economic data is virtually inaccessible. Politics, well, there's a premium on being seen to do something. Institutions don't like to be wrong. They don't like to be shown they're wrong. They don't like to have their wrongness published. They desire high ratings and low risk, which is nice if you can get it. Specialties and providers, like me, desire control. We want to be the ones allocating resources. We want access to the patients. We want to have influence and esteem within our community. We want to be the directors of patient management. We want to be the nexus of communications. Every conversation should include us. Freedom to act as we wish, because we're really very important. Well, these are the natural influences on the folks who are charged with taking care of these catheters. And we have to account for these things in our practice. If we don't, we're going to be led easily astray. Myth and legend perpetuate ingrained practices. The way we do things here becomes a best practice. And change is threatening. People will give up clothing, housing, sex, wealth to not have change. It's that influential, right? So what does this lead to? Well, we do things when we don't know what we don't know, like someone mentioned earlier, pull that catheter. The tip's in the wrong place. Pull that catheter, we don't use that catheter here. Well, as you know, if it's your catheter and it's, one of few remaining venous pathways, the fact that they don't use it here is probably not the most important feature. That catheter, by the way, I'm not sure if I can go backwards. Yep, is an antibiotic-impregnated catheter, 15 times lower rate of complications in chronic use with that catheter. It's no longer on the market because it costs $10 a unit more. Yeah, that gives you pause for thought, doesn't it? Pull that catheter, I think it's infected. Go into the emergency room. Well, I've got a fever, I've got a catheter, shaking chills. We'd better pull that catheter out, here's some antibiotics, see you later. You might want to see somebody about getting a new one. It really decreases my overhead in the emergency department if I don't have to write a lot of notes or gather a lot of labs. I don't have to follow up on the labs that I don't get. I don't have to pay penalties for catheter-related infections that I don't prove. Patient histories are not accessibly maintained. This patient, as Ali said, on the outside may not look sick. All the black squiggly lines are collateral veins. None of those black straight lines that you don't see are the common central venous pathways. This child's 9 years old, by the way, and doesn't have a named pathway left to his name. We do see a stent down in the groin it's not open. We see a hemodialysis catheter in the other groin. What does that tell you? That they've exhausted every other route of access, and now they're down to the quote-unquote end. We'll come back and save him later. Current systems don't facilitate communication. There's no durable linkage between the patient, the device, providers, and events, and also location, right? Because you don't just go to one hospital for care. If you live in Florida and you go to Pittsburgh to visit me and you need a physician, you're going to go to the physician in Pittsburgh who knows nothing about you and can know nothing about you through the medical record. Reporting isn't standardized, it's not structured, it's often not done. Standards are siloed. We have surgical standards, IR standards, nursing standards. They're speculative and dogmatic. We're very sure that this is what we believe you should do, but they're not evidence-based. We don't even have a common vocabulary for what we do. Silos of expertise isolate information. I know everything about, if I'm a surgeon, the way surgeons put central lines in. I know where we have the lowest rate of complications for surgeons. But it may be that the lowest rate of complications for me as a surgeon is 10 times higher than the highest rate of complications for me as, say, an interventional radiologist. So that isolation of information in a silo can be harmful to the patient's interests. Silos also maintain cultural and linguistic barriers. If you can't understand what I'm saying, you have a hard time criticizing me, don't you? Differences lead to loss of trust and morale. If, as Ali described earlier today, several of your providers are saying exactly opposite things, how secure do you feel? There's an enormous pressure to achieve 0 complication rates, but is 0 really achievable? Are we aiming for the end of the ladder, or are we aiming for the next rung? 0 is the end of the ladder. We're not going to get there in one step. Infrastructural friction inhibits collegial performance. If I think I'm the bee's knees of venous access, I'm not going to have that conversation I should have with a surgeon who knows more about something I need to know more about, or with the patient or their family. Let's talk about complications, because we need to recognize what they look like when they happen and what to do to prevent them, and then what to do when they occur. So, elective decisions during catheter insertion include who provides the service, where and how it's performed, the type of the device implanted, whether it's tunneled or quote-unquote temporary, non-tunneled, what material is the device made of, silastic, polyurethane, is it coated, is it cuffed, how many lumens does it have, how big are the lumens? If you say, I don't want my child to have anything bigger than a 6 French catheter, and they come out with a 9.6 French catheter, that would never happen. But that's an elective choice that's made at the time of insertion. I don't think it should be the elective choice that's not elected by the patient and their family, but side and size of insertion, site and side of insertion, and catheter tip position. These are all elective decisions. Sorry, I thought I took this out, that are made at the time of insertion. So we need to recognize complications when they occur from any route of access. These are 4 routes of access. On the far left, internal jugular. The next one is subclavian, which is often actually brachiocephalic. The third one is a peripheral access. Here you see a peripheral port. And the fourth one is transfemoral access. So these are access to the 6 routes that we have normally available to us. But they all carry potential complications, some of which are common amongst them and some of which are unique. I can't puncture the lung from the arm, but I can from the neck. I can from the groin potentially. I can puncture the heart with any route of access. I can, if I use subclavian access, puncture the costoclavicular ligament on the way in, which can grind at the catheter through its lifetime, cause the catheter to fray and break apart or leak. That's catheter pinch-off syndrome. Only happens with the subclavian, nowhere else. So we have to consider the implications of the route of access that we select. We have to consider how we're going to find that vessel. I don't know if you can see in this newborn, in the groin, there's a catheter that heads up to that arrow. And I don't know if you know where that arrow is in the venous system. But if you don't use guidance to put in the catheter can end up in places that you don't intend. And those actions have consequences. In this case, you see the little dot with the arrow there, a little white dot. That little white dot is the left iliac artery, which is not a great place for a venous catheter. But that catheter was in that location for 3 months of this infant's life. Consequences, leg length discrepancies, loss of limb, loss of arterial flow, not a great thing. So, and that's a quote-unquote temporary catheter that was in for 3 months. The reason I use that 5-day boundary for temporary versus chronic is because catheters that are intended for less than 5 days of use should be replaced with a permanent catheter as soon as possible. And by permanent, I mean one designed to decrease complication rates over the long term, whatever device that might be. Inadvertent arterial puncture may not be entirely avoidable. You know, in the best hands, you know, with the best intentions, it's possible to hit an artery inadvertently, but we need to recognize it when it happens. In this case, you can see the wire crossing beyond, from the patient's right shoulder, which is to your left, beyond the spine to the left side. Well, there's no vein that goes that way. So the person putting in the device needs to recognize that that's an arterial catheter. This is a venous catheter in the same patient, so you can see that it's on the right side of the spine where it belongs. Well, this is another patient who had a PICC line placed in the brachial artery. That arrow should be far to the right of where it is, but you can see the big, bold, black column of contrast there that cuts off abruptly. And that cutoff is where blood should be delivered to the hand and arm. There's the hand. You can see the forefinger is nicely blushing with contrast, and the rest of the fingers, which were lost, subsequently were not. So these things have consequences. Nerves are also vulnerable during venous access. You can see the big black hole there, that's the artery. The little black hole to its left at 7 o'clock is the brachial vein. But where that open arrow is, that little bundle with dots and holes, that's the brachial nerve. It's sitting right on top of the neurovascular bundle. If you don't recognize it for what it is, then you can perforate it. And this is a long view of the same patient with the catheter going right through the nerve on the way to the vein. Exquisitely painful from the moment it's put in until the moment it's taken out. But if people don't recognize what they've done, they try all kinds of things, you know, warm compresses and, you know, aspirin and whatever, right? Nothing's going to cure that nerve until the catheter isn't going through it anymore. This 16-year-old girl needed a long-term intermittent access for chemotherapy. So you can see a port down there on her side that comes up, and we can see the path that it takes. And the catheter tip location in this patient is, you know, pretty good. Its pathway, though, through the lung isn't so great. And so, not understanding how to get from A to B, and when you're not going in the right direction, can be a real problem. This is a 2-year-old boy with retinoblastoma. He's receiving chemotherapy, and we can see that his catheter has a hairpin turn from the port hub up into the neck and then coming down toward the heart. Well, that hairpin turn wants to uncoil itself, and it can only uncoil itself in one direction. It's not going to go further in. It's going to come farther out. And so we would like to see that catheter take a nice, gentle course like this to the heart, but what we see in this patient is that it heads up high into the neck where the puncture occurred before heading back down. And so the puncture site choice was what led to this complication. So each of these elective decisions have consequences. This is the catheter 14 days later having pulled out from where it should be and no longer functioning. We visited this boy earlier, 9-year-old boy with multicystic dysplastic kidneys. He needs hemodialysis access. Every named pathway is occluded. And so do we send him home and say sorry? He's getting peritoneal dialysis, but it hasn't matured yet. So he still needs access until that happens. And this is something that I really want to encourage you with and make you aware of, is that there are many pathways to get to the right heart. Sure, the 6 major pathways are the most convenient, but here we're going from the skin under the kidney, that's the liver up there on the left, down to that black hole, which is the IVC, the inferior vena cava, coming toward the heart. So this is translumbar access. These alternate routes, translumbar, transhepatic, intercostal, transthoracic, and other non-conventional routes must be exploited when conventional routes are no longer available. Now, when I say no longer available, just because a route is closed doesn't mean it's unavailable. It means there's some hard work ahead to get access through it. It also doesn't mean that that route's going to be open at the end of that procedure. But what we want is access, not necessarily flow. There's collateral pathways that the flow can go through. What we need is to have the tip of the catheter near or in the right atrium. And so that's what we end up with here, catheter coming in through the muscles of the back into the IVC and up. That open arrow there is in the right atrium above the liver there. Some routes, alternate routes, are much more durable than others. So transhepatic routes, not very durable because every breath you take wants to dislodge the catheter. Okay, thanks for that. Have you been putting more of those out? Oh, that's great, okay. She's marking time to help me know how far behind I am. So alternate routes can look ugly, but at the end of the day, we want the tip of the catheter near the right atrium, and if we can get it there, we've achieved that purpose that allows medications and blood draws and other things to occur that need to occur. Without that access, say, someone with short gut who needs liver transplant will be taken off the list. They get on the list when they have really bad access, and then they lose another access, and now they're off the list again. So we want to keep them on the list if they need to be on the list. We want to prevent them from getting on the list if they don't have to. This is a left subclavian port. 22 days after insertion. Now, most of the time we're putting in ports for way longer than 22 days, but it's not working. That lumpy, bumpy course tells us that it's fixed at 2 locations. It should only really be fixed at 1. And so the second location is the problem here. I mentioned earlier the costoclavicular ligament from a subclavian approach is what caused this catheter to malfunction. We can see it coming between the clavicle and the first rib, on its way actually to the brachiocephalic vein, because very few subclavian catheters ever touch the subclavian vein. So a port was placed, the tip of the port stayed in a good position. The port was removed at the end of therapy. The story's not over. When the catheter is removed, this is a subclavian catheter again. You can see where that red arrow is, where it passes through the costoclavicular ligament. You can see how much of the catheter remains after we pulled the port out because it broke off where it crossed through the costoclavicular ligament. And so we had to go snare. You can see a snare coming up and grabbing it from below, snare that fragment and take it from the heart out of the body. So again, these elective decisions have consequences. Proper tip position remains controversial. If you read the surgical literature, they'll say one thing. If you read the renal dialysis literature, they'll say another. IR says another. European, American have different points of view on these things. But at the end of the day, if you can't see the cavo-atrial junction, for example, where the superior vena cava meets the heart, then you can't say where the catheter is in the venous system. If you can't identify systemic veins, you can't say that you're in them. How then do experts confidently identify the location of catheter tips? Well, I don't rightly know. Is the cavo-atrial junction level with the carina? Some literature says yes. Or the right heart border inflection. Again, some literature says that's where it is. Well, it's not. It's sitting about 2 vertebral bodies below the carina from birth to death. So what does that mean? Let me just show you. So the carina is where the airway divides into the bronchi, and we can see that on a plain film. We can see, so that little V there, upside down V, is the carina. We can see the right main stem bronchus, that red line. We want the catheter to be below the right main stem bronchus, below the carina, in order to be near the cavo-atrial junction. And you can see the vertebral bodies, and if you use them like a ruler that grows with you from the time you're born to the time you die, then you can find that point, 2 vertebral bodies below the carina, that you can actually aim for in your procedure and judge against when you're looking at subsequent imaging to see if the catheter tip ever was where it belonged and whether it's moved from where it belonged to somewhere else. If it's moved, it puts you at greater risk. If it was never there, it puts you at greater risk. Somebody needs to be aware, who's caring for you in your catheter, where these things are. I'm going to just skip ahead because I'm sure that the 5-minute flag's coming soon. So I'm going to talk about some non-conventional access routes. Some of these can be quite durable. This one, 17-year-old boy, renal failure, lost 6 of 6 conventional central venous pathways, both internal jugulars, both subclavians, both brachiocephalic veins, and both femoral veins. Lots of collaterals. But his chronic hemodialysis was transhepatic. It's not working anymore. And so what do? Well, we don't throw up our hands, right, Ellie? We do not throw up our hands. And we do not say, well, you've had your last access. What we do is find a new way home. So in fact, this ultrasound on the right shows a pathway from the skin to the kind of nub of the brachiocephalic vein at the origin of the superior vena cava. It's not an easy route. There's lots of things like lung and artery that are in the area, but under ultrasound you can see through that whole course. And the upper line, the lower one's a chest tube unrelated to the procedure, but the upper line is a hemodialysis catheter. It looks beautiful, right? It's not taking a normal conventional route, but this catheter lasted for at least 500 days. That's when I last had follow-up on him, after it was placed, which isn't a bad extension. We can add up to 30% to the useful lifetime of catheters in high-risk patients on average. Salvage procedures. This port at 538 days no longer functions. Well, 538 days isn't a bad lifespan for a port catheter, but if you need it for a lifetime, it's not adequate. And so we've got to figure out what to do about it. Well, here the problem was that there was a little tip clot. So You can see the dark spray of contrast not going straight forward. So there was a ball valve mechanism at the tip preventing it from withdrawing blood. So we put a snare up and stripped the fibrin sheath off the catheter. That means we didn't have to take that port out and put a new port in. We could salvage the port with an easy transfemoral procedure. In this case, I used a tip deflector wire, but you can see the stream going straight forward now, as it should. It functioned well. This woman with lymphoma, the catheter obviously is going in the wrong direction. And again, a tip deflecting wire, which you can see hooking over the catheter there, was used to pull it down. And she continued to use this catheter for an additional 270 days until she was done with her need for that catheter. Salvage procedures also have long-term consequences. This is a 7-month-old multivisceral transplant candidate. Can't get a multivisceral transplant if you don't have reliable access from above the diaphragm. He has no named veins left. You can see a series of stents that were placed in France and England. So stents in a 7-month-old are going to have consequences. They're permanent foreign bodies, and the stents here were completely occluded. I ended up going straight across the chest. You can see that double track there is the end of the stent towards the shoulder. That bright line is the needle going into the end of the stent. And so this is what an injection through that looked like, which obviously isn't all that normal. But we were able to burrow down, and here's an example where we have access to the right atrium. All those vessels are still closed, but now he's a candidate for transplantation again because he has durable access from above the diaphragm. And so here's the end of that. That tip is right at the cable-atrial junction. And he continued to use that for another 2 years until he got his transplant and intestinal rehabilitation and didn't need it anymore. So the bottom line is, not what we're capable of doing. Well, I think I'm going to make it. Emily, your encouragement is fantastic. Thank you. So, not all the magical things we can do, but that things can be done. This is a 1-year-old truncus arteriosus patient, and they'd basically written off access from above the diaphragm. But you can see a little nipple of contrast where the vein used to be, and we can eat our way from there forward with balloons and reopen that pathway. Again, it's not that it's a no-risk procedure, but at the end of the course there, we have a PICC line into the right atrium. Well, that means I didn't have to go in another pathway that hadn't been used yet. So if I can salvage that pathway, even if it's only for another few years, that's a few more years that the other pathway got to grow and wasn't punctured and so isn't complicated. This is my last case, if I'm down to the 1 minute. A 68-year-old gentleman with heavy metal poisoning needs chelation therapy, had this port catheter in for 11 or more years, 12 or more years. And there were several areas of narrowing along that vein, subclavian. You can see a balloon on the right starting to blow up. You can see where that balloon looks like somebody took a hole out of it. That's where the narrowed vessel is, and that point is where the two brachiocephalic veins come together. 1 lesion, 4 pathways. Okay, so that's not a good thing, right? 1 lesion, 4 pathways. But with balloons, we were able to open it up. The final balloon on the right is a paclitaxel-coated balloon, a more recent addition to our armamentarium that inhibits ingrowth of the intima that would tend to clog this back up again. So hopefully we'll stay open. It has so far for him. Our approach has been in every case to begin with the least invasive technique and advance until we're successful or encounter a boundary event And that would be something that exceeds the risk-benefit ratio, which is going to be different for each patient. The more benefit there is of having a catheter, the more risk we can absorb in trying to get access. Okay, so what can you do to help? We need you, and this is kind of a segue into our next session where we're going to take questions and have a conversation, but you guys are the only stakeholder routinely aware of critical central venous access related events across time and venues. Meaningful components of care need to be meaningful to you, not to me. We need accurately measured outcomes, and you need to validate their accuracy. You, your families, patient support representatives. When patients challenge providers and actively participate in decision makings, outcomes improve and costs decrease. So don't feel like you just have to close your mouth and take it. You're not helping yourself, you're not helping anybody else. Speak up. If you need help speaking up, there's a lot of resources around to help you stand for yourself. Patients often feel excluded and are often dismissed. And so you're going to need some leverage, you're going to need some help. We're working on developing a patient-facing platform to improve data completeness, validity, and to empower patient self-advocacy with evidence that you can access and you can hold up to the provider and say, read this before you touch that. I thank many in this room, including Beth and Allie, who helped us put these guidelines together, published in JPEN a few years ago on evidence-based strategies and recommendations for preservation of central venous access. In this case in kids, but most of what we say applies. Oh, I should just point out that the authorship list here isn't just people who look like me, right? There's pediatric surgeons, interventional nephrologists, nurses, PIC nurses, intestinal care nurses, an ID specialist, world-leading ID specialist, hematologist, and so forth. I can't read them all. Transplant surgeon, Sam Kokocius, pediatric gastroenterologist, and so forth. And the Venous Access National Guideline and Registry Development Patient Advocacy Panel, right? Affected Persons Advisory Panel. So this reflects your point of view, not just mine. And our most recent publication just coming out, where we're talking about developing a national system, a national coordinated registry network to gather valid data to provide evidence to support practices and to restrict practices that aren't safe. So anyway, thank you so much for letting me come and talk to you, and I'll be glad, thanks, to continue the conversation in our panel to come.
First of all, thank you, Dr. Baskin, so much. And if you're confused, it's because we flip-flopped a session because we were waiting to see if she would be able to make it. And so we went with Dr. Baskin first, and she is not. So we're going to spin on a dime, and here's what we're going to do instead. Open it up to questions for you. So the first thing I want to do is say, that was terrifying. Was that terrifying to anybody else? Or am I alone in that? That was terrifying. So thank you for saying it, but we're terrified now. No. I'm saying we need to have this conversation, right? The question is we don't know what we don't know, and the experts don't know what they don't know. And we need to talk better. And so that's why I'm so excited. So Vanguard, partnering with Oley to be able to say, how do we get good data? So Vanguard specifically is a 501c3 as well. So they're a nonprofit. This is what they do. That's all they're trying to do. We're trying to collaborate even better. One of the questions, and I'm going to leave this open to you guys in a second here, is if you were listening to that in the way that I heard that, is experts matter. There's an expertise there that is broad and deep and wide and so forth, right? I don't know that I always have access to experts. So you may not either. And more importantly, how do I know if the person who I'm talking to is an expert? How do I identify them? Loaded question.
That is a challenging question. How do I know them? You know, and so, you know, word of mouth. Beth called me about, you know, who do I see in Florida, in my part of Florida, or do I have to travel, right? Yeah. And so I called, you know, a close friend who is in Miami, who I know the quality of his work and I know his standards, right? And so I said, who would you recommend in Tampa? I know you can't go from Miami to Tampa, and I don't want Beth to have to take Manny from Tampa to Miami if she doesn't have to. But so he you know, partnered us up, you know, with an pediatric interventional radiologist close to Beth. And I hope that, you know, we could potentially put some sort of a resource group together within Oley.
Healthcare professional directory of Oley's may help.
Right, right. And so I think that's probably an answer is, you know, to have a pool of people we believe in and support them and connect you guys with them. And sometimes it's just answering a question. It may not be that you need someone specifically to do something, but you need to know what's possible, what's not likely to be beneficial, what kinds of questions to ask. And so I'd love to see us develop those sorts of resources, you know, through this community.
Yeah. So I'll tell a really quick story. Well, I'll try to make it very quick. So Manny has had this particular line in for 2+ years, right? He's bringing you a microphone so you can move around too, I think, eventually. Oh, no, she's going to ask a question. So he's had this line for a really long time. It started to where he could flush and he could get his PNN, but we couldn't get any blood return. So in the old days, that used to be an emergency and we have to run in, blah, 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 right? So now I have it to where, you know, it's going to be, we're at 2 weeks, so I knew I had up to 2 weeks to be able to do that. Now, I'm not recommending that. I'm not saying that that's what you need to do if you don't get blood return, because that is a sign and symptom of something not going right. My team made an executive decision that just says, in his case, we feel like this is a safety thing and so forth. So we were able to do that. Fast forward, you know, TPA, repeat TPA, it would last for a little bit. We could get blood draw for that day, et cetera, right? Fast forward a couple months later, it's intermittent. And so I'm like trying to limp it along. Like, is it a real big problem? At the end, we ended up needing to have an escalation plan. Now, you just saw, I don't know if you saw it, but 2 of those slides say there were some guidelines and standardy kind of things. My name is literally on those. Like, his name's on those, my name's on those, and I cannot get an escalation plan. So me, being me, can't find a path forward for these things. I'm like, we need to do a better job. So, I mean, I have him in he's a phone-a-friend, right? And I cannot get this done. It was ridiculous amounts of nightmare. Fast forward. We ended up, and I don't think I already told you the story. So we ended up in IR. They do the venogram because that's the next step they should have done. They didn't even do a tip x-ray. They didn't know where it is. I mean, I could not get this done. This is February and March of this year. We're not talking a long time ago. And trying to skip over stories. Finally got into an IR. I had to go through the adult side because there isn't a pediatric IR in that particular area. That guy wasn't available. It's another long story. And so they ended up putting us in. He does the thing and says, oh yeah, it's very, very occluded. Great. Well, what are you going to do about it? Oh, I don't have orders for that. Normally I would do blah, blah, blah. Okay, so now what am I going to do? Well, now we have to set up a whole nother thing, come back. I mean, it's days and weeks that are dragging on, and this is becoming an emergency. What I know is in the past, when he's been occluded like that, eventually it gets to where I can't flush it. Now it's an emergency because he's on parenteral nutrition 20 hours a day with nothing else. So now we're in an emergency. Fast forward, we finally get it scheduled. We go in, he does the femoral. They go in to do it's a fibrin sheath stripping is something, and that would be the next natural thing to do. It went perfectly. It was great. There's a but coming, can you tell? So it goes perfectly. He is finished by 1 o'clock. He's in He had to have a little bit of mild sedation, so we're discharged at 3 from an outpatient procedure. We get home at 5 because it takes that long to get home. At 7, he spikes 105 temperature. What the heck? All right, so we're back. So we start rushing back to the emergency room. We have a flat tire on the way. I'm trying on the side of the road to decide because now he's in respiratory distress. Fast forward, it turns out it's, probably, most likely, and I don't know for sure, most likely a septic emboli, right? So, and he can explain all that kind of stuff, but it's basically, it pulled this gunk through and now he can't breathe right? To this day, the IR doctor who placed that does not know of this event. Why? Because there's no pathway to go backwards and say, hey, and I'm not even saying blame, I'm just saying he doesn't even know. So we're talking complications rate, they're always low. Why? Because nobody knows how to report them. And nobody knows how to collect that data. So all that said to say we need real life data. We want it because we want to be able to prove it. Right now, it's just theory until we have data that say these are the complications we're experiencing and so forth. So I thank you for listening to my story there. This literally just happened, right? How do we become more empowered, less terrified? And then I'm going to let them ask, what practically can we do? And I'll let you guys start thinking of questions.
Right, and so part of the empowerment challenge there is that the interventional radiologist doesn't feel empowered to be a clinician, right? He says, oh, well, I didn't have orders for that. Well, who's supposed to give the orders? He's the expert. So once that patient's referred to his care, why doesn't he feel that he can carry out that care in the way that he feels in collaboration with the patient and his family is in the patient's best interest? Well, again, politics, right? The surgeon in that institution wants to have control over venous access. And so if the interventional radiologist in that institution takes, independent steps, he gets whacked. That's the reality, right? It's not a good reality, but it is. So if we understand that, we need to hold those providers, that surgeon, accountable for that kind of behavior. There are patient liaison folks in every hospital, patient contacts, someone who can support you. Go find that person and say, look, this is ridiculous. Why can't your interventional radiologist do the thing that he understands is correct when the patient's been referred to him? How can you interrupt that dysfunctional politics within your institution and liberate people to do the right thing at the right time for the right patient? So it's about advocacy. And, as a community, we need to promote those good behaviors. We need to highlight those dysfunctional behaviors and erode them until they disappear. But it's not a thing that's going to happen tomorrow or next week. It's going to take determined effort over time as a community to achieve it. And again, it's, Allie's ladder. The bright light at the top is people do what they're supposed to do because it's the right thing to do. We're not going to get there in one step. So how can we eat away at that problem one step at a time?
I see some hands up. Thanks. I see some hands up. And one of the things that I would say, just a second, one of the things that I would say is that a lot of times I feel like as a patient or caregiver is that they'll say, know your rights. I don't think that those have been agreed upon. I said that earlier, is that's one of the things that we're working on. We're literally hired an intern this summer to be able to start working on what are our rights as long-term chronic venous access. What do we need? What are our rights? Because nobody's defined that. And rather than waiting for other people to define it, we need to define it. We should decide ourselves what those rights are and then reach out to the community and help them to do that as well. So who had a hand up first? Oh, here we go.
Hi. Thank you for your presentation. I found it very informative. I think it would be good. I have used Reed from NutriShare, has been my greatest resource. At any time I've been in trouble or I'm not sure about a procedure, I call Reed. And Reed always has all the answers. Yes, but whenever I'm not sure about something, I call Reed, and wherever in the world I am, and whatever time it is, Reed answers the phone, and Reed has all the answers.
Yeah.
But Reed's retiring in
No.
6 weeks.
No. Well, and everybody needs their own, right?
So you want to know how we can prevent Reed from retiring?
Yeah, that's what I'm hearing.
So I was wondering if there could possibly be some kind of line for people like a phone hotline that we're able to call into to speak to an expert whenever we need, 24 hours a day, just to get just to give a quick synopsis of the situation and get a quick second opinion. With the other medical, we're generally in the hospital at that point.
So you're
And to give us
saying,
a quick second idea. I mean, Reed has saved my line so many times just because of my quick call.
so you're saying you've got a retirement hobby for Reed? Yeah. Perfect. No, I'm with you. That's a.
But something that we can call into a phone line that we can call into just for something quick.
So I'll just tell you briefly. When I put a line in a patient that I know is going to need it for chronic use, or who's nervous about the whole experience of getting a line, I say, look, I'm not just going to put this line in and kick you out. Here's my number, and at 3 o'clock in the morning Sunday, you've got a question that seems silly but relevant, call me. I'd rather have that question than 3 days later have you come into the emergency department because, you lived in denial and didn't want to bother anybody. I think that's our duty as caregivers, to be accessible to the patients that we're caring for. If we don't want to care for chronic access patients, we'll go do something else. But if you do, that's part of the job. And I would encourage you to hold providers to that standard, to find and cling to providers who adhere to that standard and to ask it of them. Look, I'm nervous. I mean, these are the consequences if things go bad. I need a point of contact. One of the things that Beth and I have talked about, and I'm sure many of you have felt, is we don't know who the clinician is who's responsible for that device once it's placed. Who owns the line other than the patient, right?
Yeah, but somebody has to actually, so I agree 100%. There's not even a but coming. We own the line 100% of the time, the end, right? I also need help with that on the expertise side of that. And who owns that piece? So just one example, one of Manny's lines was in for 5.5 years. He grew, where I was telling you about that yesterday, he grew, it needed to come out, right? Because it was no longer central and it was causing major complications. They said it needs to be the surgeon who put it in that needs to take it out. Well, that's great, except now that was 5.5 years ago. I saw him once for 5 minutes after he placed the line in, and he now lives out of state. So now who owns that line? Now, well, Manny and I still own that line, but I need somebody to help with that, right? So how I would answer this question is, this is something that literally the board of trustees of Oley and we were talking about at a board meeting just last night, and saying, what are some things that we can do? We have to look in some of the legal liability issues and so forth. Number one is always going to be the recommendation to go immediately to your team. They've met you, they know you, and start to develop that. We know that that's not possible all the time, but that is the ultimate goal, is the people who see you, just like Dr. Baskin just said, you find people that eventually will do that with you and they will work on it. But is there a way that we could have volunteers to staff those kind of things that come, say, through Oley or through Vanguard or whatever, to be able to answer some of those questions? We can't tell you, go do X and give you medical advice. But so what ends up happening as a result, because clinicians can't do some of those things, they ask each other on Facebook, does this look infected to you? How's that any safer? So how do we find the truth of where to support? Truth is, I found way better advice from been there, done that moms and dads a lot of times than the clinicians, but that's not safe either. So it's the halfway point. So
Right,
there's
and
not a perfect solution.
And I wouldn't maybe frame it in terms of ownership, because you own your line.
Yep.
And you own your healthcare information and, so forth. You own your consent. Don't give it away cheaply, right? But someone needs to be clinically accountable for that catheter.
Good word.
There are other situations that are similar in healthcare where those who maintain chronic clinical accountability are compensated for the effort. Because at the end of the day, as much as we would like to be available for all people for all things, it's a job, and we have fiduciary responsibilities to our groups and hospitals and so forth. If we don't carry out those responsibilities, we're not going to be here to care for you. So we need to explore pathways to make sure that there's a compensated individual who is clinically accountable for the catheter from the time it's placed until the time it's removed.
Absolutely.
And if so, at the time it's placed, that person should be identified and accept responsibility. And before that person loses that accountability and responsibility, they have to hand it off to someone else who accepts it.
Yep.
In broad strokes,
In the perfect
that's
world.
the answer to your question, is in a perfect world, that's the answer to your question. Then if there's clinical information that bears on the line that signals there may be a problem, that information has a target. Right now it just exists, but nobody's looking. Right?
Yeah.
You have a fever and
Disconnect.
rigors and hypertension. Who knows? Who's going to order the cultures? Who's going to follow up, right? We need a person who bears that responsibility and to whom that information goes.
Yeah, absolutely. So I see quite a few hands up. We're going to try to go as quickly as we can. You're next, and then I'm going to come straight over to you.
So I had a very specific question in terms of Hickman lines in particular. I've had PICC lines, Hickmans, all of the above for about 2 years. We can never seem to figure out to have a line last more than a couple months for me, which is becoming a real problem with access sites and infection risks and all of that. And my doctors have been moving more towards now small bowel transplant. And I'm trying to figure out, what are we missing? Is there something that can be changed with my lines that may delay that from happening?
So are you losing the lines because of infection or?
Everything. I've had 4 central line infections in the past year alone that have all resulted in sepsis. I've had the Hickman cuffs migrate out of my skin even when the suture is still intact. It's out right now, so I have to go tomorrow to have it exchanged. It's just all the above. Or it stops functioning, so then we put TPA in it. A day later, it stops. And we've done that like 5 times in 1 week before. And then they're like, we're just going to exchange the line. So many different things. And I'm just like, are we missing something? But I think this also goes back to what you're saying with there's not really an ability to report when these issues happen, because then I ask my doctors and they're like, oh, that doesn't usually happen. But then I ask my other chronic illness friends or other people that I know have a line, they're like, yeah, it happens to me all the time. So I feel like there's this huge disconnect, and it's like, how do we fill that gap so that things like this could have solutions versus just exchanging it out because that's what's easier in the short term.
Right. So just a couple thoughts. One is exchanging it out, right? If it were a port, we would go and strip the catheter to retain the port in place. But a PICC line, they're just going to pull it out, or a Hickman, they're just going to pull it out and slide another one in. Problem is, if there's a fibrin sheath around the catheter, like the finger of a glove, and you take the finger out and then you put a new finger in, you're putting the new finger back in the old glove. So if you don't disrupt the glove, if you don't tear up the fibrin sheath, then you're going to have the same problem a short time later, right? And so that may be contributing to that sort of problem, that just replacing things over a wire doesn't take care of that issue, and you need to be working with someone who has that in their tool belt, right? If they don't have that tool in their tool belt, they're just going to slide one in behind the other. So you may need a more sophisticated provider, or you may need to have that conversation with the one you have. Recurrent infections, such an issue, and I can't tell you the number of patients that I've taken care of who have never gone more than 2 months in their catheter lifetime without a central line associated bloodstream infection. Kids 6 years old who've had 60 infections. It really is horrifying. I started using antibiotic impregnated catheters in those patients and cut the rate to near zero, not zero, but near zero, just by virtue of having an appropriate catheter for the task. That catheter is not on the market currently, as I mentioned. So we need to advocate. Part of the reason it's not is because FDA changed its requirements for approvals that had been gained over a period of time by similarity to existing devices. We need to work with FDA to say, look, you're killing people, you know, by causing these kinds of devices to be taken off the market. And you need to work with us to help these vendors provide these solutions.
Innovation. Yep. We need innovation.
We need a lower threshold for innovation, and part of that, sorry to get a little technical, is post-market surveillance. In other words, not having to do pre-market clinical studies, prospective, arbitrary, stupid, expensive studies, but get the device in patients and keep track through registries of outcomes. Don't do silly things, stupid, dangerous things, but things that seem to be sensible, and see how they're used. And give approvals based on use, not approvals based on the cheapest disease that we can prove it in, which is the way it's done now. Through surveillance, you can cut the cost of a new device innovation from 70 million to 30 million. 30 million is not small, but it's a lot smaller than 70 and a lot more likely to get through the process. So there's no simple answer for you as an individual, although you know some of those issues around the fibrin sheath might be addressable.
Well, and what I would say too is, I'm going to go here with the question next, but what I'd say is he's going to be in the exhibit hall at the expert table, which is right next to FreeArm. I think it's next to FreeArm. And so if you have some specific questions, he can't give exact medical advice for you, but he can be a little bit more specific there if that's something you're interested in.
Thank you. Lovely and very informative presentation. Thank you. My name's Richard. I'm from London, as you can probably tell from the accent. I'm one of the trustees of the equivalent of Oley in London called Pint. One comment and one question, if I may. The comment is, in London, we're able to track our readmissions from billing data, believe it or not. So we've only got one clearinghouse in the UK. And it would be interesting to see whether you might be able to get your clearinghouses, I know you've got multiple in the US, but actually join up into a public health information network we call FIN in the UK. And secondly, complete opposite to the lady that asked the last question. In the UK, I'm fortunate enough to have had a line in for 10 years, infection-free. But we have a rule, in inverted commas, that lines must be changed at 10 years. But on label, they're supposed to be as good as condition, should we say. What's your thoughts on pulling a line at 10 years, or is there a difference?
So I mean, in part it depends on where you are in your growth curve. I don't think you're going to be growing a lot more, so that's probably not an issue for you. But for Manny, it was, right? Yep. So if you start with a 5-year-old and they get to 10, not even 15, right? They've probably outgrown their line. And so somebody needs to be doing prospective surveillance. That's part of the guidelines that we published, and I'd encourage you all to read them. Ali and Beth and others in the room have and gave us their opinions, but read them and see what you think, and let us know what you think. But that's in there. That systemic attention to readmission rates is present in the US. It's done through CMS, but getting access to that data is problematic, and incorporating that with registry data, which is the purpose of a coordinated registry network, is challenging. Interoperability, which means having words mean the same thing in every place they're used, is a challenge worldwide, and so that inhibits the transfer of quality data as well. These are all issues that we're working on. I've been working on them since 2006, and I'm about that much further along the road. I mean, I'm at rung 2 instead of rung 1, but I'll keep going until I fall down or get to the top. But great suggestions, and as far as advice about 10 years or not 10 years, irritation of the vein can lead to, say, calcification and adherence of the catheter to the vessel wall over time, especially as they get out towards 7, 8, 10, 12 years. It's going to be different patient to patient, but I think that's a caution to keep in the back of your mind, that even if the catheter is continuing to work well, it may not be playing nicely in the sandbox that it's in, and so sometimes a new site can be a safer alternative.
Or at least an evaluation, the conversation, because there's nothing magical that happened on that birthday. Kind of like I have 5 children. The 5th one just turned 18, and so this is my 5th child to go through 18, and there's nothing magical that happens the day you're right before your 18th birthday, and then all of a sudden your 18th birthday. But everything changes, at least in the U.S. that day, other than that you can't drink or do rent a car. Other than that, like that day before, I had to sign everything. That morning she woke up and all of a sudden I can't sign anything. It was a magical day. There is nothing like all of a sudden she's all of a sudden mature, right? And it's the same thing. I don't think the day before 10 years it was fine, and then, oh no, the day after 10 years it's not fine. So I think like some guidelines, when do we evaluate it? How does that get evaluated? These are questions that I think need to be addressed in that whole list of things we don't know. This is another one. How long can they stay in? What are there signs and symptoms that are happening below the surface we don't even know are happening? Okay, well then how do we evaluate that? Nobody seems to know what we should do. I think there's some ideas on what we could do, but we haven't decided.
So with respect for Emily, who's flashed me my final card, we probably have to, not yet? Oh, I got 5 minutes.
I know,
we can get in 10, 15 more questions. Let's go for it.
Yeah.
No, I agree with her, yeah.
Okay, so I've had lines that have lasted more than 17 years. I had a Hickman that lasted, it was still patent when they took it out. I've had lines last 4 days where I never made it out of the hospital because it had a hole in it. So all different lengths. When we're in crisis, if we don't have a person that we can call at 3 in the morning, we end up in the ER. And the ER is the right place when you have 105 fever and sepsis and all that, but the ER is also the worst place for us. It used to be that doctors could call in ahead of time, let them know you're coming, and you'd get they could route you to a room automatically without having to go through the ER. You're right, a direct admit. My hospital doesn't do that anymore. I know it's big structural change to get an ER to be, or any ER, all ERs to be more open to the specialties of what we need, and we're a population of 20,000 or something. I don't know how many we are, how many people have central lines. But what do you see in terms of anything moving in that direction where ERs are not so fraught for us, like they want to immediately pull lines and we have to fight them on it and things like that?
So, if your needs are urgent, if you've got evidence of septic shock and organ failure or, so forth, right? Then you need urgent attention, right? And no question then the ER is probably the right place for you. If you've got a fever and, and maybe a little pus at the, entry site, we need to attend to it, but we don't need to attend to it in an ER, right? And so how can we get you to the right place at the right time? Our patients in interventional radiology, we tell them, look, call us, and we'll have you come to us, either to our clinic or to our procedural area where you'll be treated as an outpatient. If you don't need sedation or anesthesia to attend to your problem, then we can just take you there directly, as an outpatient. And because we don't like our patients going through the ED, it clogs up the ED and it exposes them to all sorts of things that they don't need, and it's 10 times the cost, right? So I would explore with a provider like your interventional radiologist or whomever, whether that's a possible route for you when you have a problem that doesn't demand urgent attention, even if it did, right? You can come to us and we can send you to the ED, right? We can triage you. We can send you to the ambulatory surgical unit for processing for a procedure that does require sedation or anesthesia. So there are still pathways that can usually avoid the ED. I think it doesn't necessarily mean changing the way the EDs work. It may mean changing the way that you interact with appropriate practitioners.
I actually agree with that. One of the things personally that we've done, if you need to go to the emergency room, please go to the emergency room. That's where you need to be, the end, right? Like you just need to be safe, right? But what we do personally is when we have an issue that we've never encountered before, we're going to do whatever we need to do. And then I look backwards and I look forwards and say, what part of this was preventable? What part was not? What part was there interventions we could have done? What part of the system worked? What part of the system didn't work? Because if this ever happens again, I need to do a new plan of action. So for example, if this happens, I'm not going to the ED. If that happens, I am. And then I'm going to do these phone a friends, or I'm going to do this call, or I'm going to do this proactively. And so every health system's different. Your insurance is different. Your symptoms are different. Your line is different. Your needs are different. So we can't change the system to fix us. So what we have to do is to say, how do we best use the system to work for us? And I know that sounds easy, and it's not. It's long, it's hard, it's complicated.
So I thank you for your presentation. It was scary, but very amazing at the same time. So I want to tag on to what you guys were talking about and what I also said when I said it's my line. So you're eventually going to retire. I hope so, for your sake, that you get to enjoy your whatever you want to do.
Reed and I are starting a bit.
Yeah, you're starting something. Yeah. So once you retire, my issue has always been nobody will take on your case afterwards, because then you're dropped, because your patients don't automatically go. And let's just say in the larger healthcare systems, the smaller healthcare systems, honestly, I think are better in this instances. But the larger healthcare systems, like the big ones, and I'll just say Pennsylvania, yeah, you don't just go to the next, you're not passed on to the next logical person initially, and then I schedule an appointment and have a conversation to see if they still fit. There's not a good handoff system. What do you think about, how are you going to what is your plan to hand off your patients to the next physician, clinician to take care of your patients?
So I spent most of my career at children's hospitals. And the last children's hospital I was at, as I was leaving, I had a chat with a fellow with whom I'd worked for a long time and who I really respected. And I was in tears because I felt like these kids depended on me, and I was there to help preserve their life and work with them. And now I'm leaving, and what's going to happen to them? And he looked out the window, which happened to overlook a cemetery next door, and he says, look out the window. He says, that place is littered with indispensable people, okay? None of us are indispensable. No matter how much we care, no matter how good we are. But, I think Allie's talk really is right on target for this question, which is they're not retiring tomorrow, right? So you need to start having these conversations with providers that are moving towards retirement and do some estate planning, Say, look, I notice, that you're still young and fresh, but getting on in years, and eventually you're going to want to walk away and do something different. And so how can we begin planning for that transition, right? That's the way to do it. Don't wait until they go away. You can, people are going to leave town, they're going to move to other places. And if you don't know, as soon as you find out, begin that, even if you don't need help today, begin that process. It's not always going to be a smooth transition. It's not always going to work that easily, but where you can, look ahead.
I've purposely, consciously, very methodically built a network for myself. That's what works for me. So self-advocacy for me is like, who do I know? And so now I have, those are in my network. Well, now I know him. So everybody in his network is also in my network. And then, so if he were to retire, he may hand me off to this person and everybody in there. And not everybody's going to work for every situation, right? But I need to know everybody. And so I say it probably a little crudely is I collect people. That's what I do. I collect people like, ooh, they notice things, they know things. I'm going to go over here and see, like, do we work together? And I consciously, purposely continue to build that because people are going to retire and move on. First of all, thank you so much again to Dr. Baskin. Can we give him a hand? Thank you so much for being here today. Thank you for your time and attention, and we want to continue this conversation as well. What we would like to do is invite you now. We're going to go into the exhibit hall is open, lunch is open. Hopefully there are more lunches today. Apologize if yesterday you didn't get one. And then again, he's going to be in the exhibit hall at a table if you have some specific questions. And then this afternoon, come back for one of the breakout sessions. We'll see you in a little bit. Thanks, bye.